I'd like to thank the scientific committee for inviting me. Uh, I've been asked to speak on a nomogram-based management of keratoconus, and which is something that we've had good experience with, and something that is seen quite commonly now in terms of diagnosis, especially. No financial interest, but it would be nice to have some. Interventions for irregular corneas could be both in front of the cornea, on the cornea, in the cornea, and sometimes even behind the cornea. So in terms of front, you got specialty contact lenses. On the cornea, you got a combination of collagen cross-linking and PRK. In the cornea, you got rings. Sometimes people are combining with SMILE and CXL, and something beyond with the use of phakic lenses, and it's sometimes, very occasionally, IOLs as well. I'll start with one of my patients, a government employee who underwent cataract surgery. This is 10 minutes, right? Yes. And underwent cataract surgery in 2001, referred for some cornea problem because of unsatisfactory visual recovery with no retinal pathology. His best corrected was 6/18. When you look closely, the patient had actually undergone a LASIK by one of the most famous LASIK surgeons, and this was missed preoperatively. So if you remember your Hamilton, people who don't know the history are doomed to repeat the mistakes. So he had actually undergone bilateral LASIK about 10 years back, and he had -10 in both eyes. And when we put this patient on imaging, we found he had a central corneal ectasia in both the eyes. And at that time, the suggested treatment was collagen cross-linking and probably with an intact. So we went ahead with it, and that was the conventional wisdom. And follow-up, his vision was actually quite good. He came back probably by 2013. We had got a new laser machine with an advanced software, and I had also become wiser. But what we find across the pupil, he had almost about 6 to 8 diopters of astigmatism and irregularity. We planned a TopoLink guided PRK in the right eye, probably give him a pair of glasses in left eye, a customized cataract surgery. So a cornea like this, which had central ectasia, with a bit of planning where you do a topography-based treatment. Broadly, what it means is that it will treat, if this is the area of the ectasia, it would treat the steeper parts first and steepen the flatter parts, so you got a more regular cornea. Similarly, in the left eye, if you see the ectasia is in the central part, and the laser treats that steeper part to flatten the mountain or the steepness. Postoperatively, when we put him on the eye trace pre and post, you can make out there is a bit of improvement in terms both of the clarity of the vision and the irregular way the cornea was. You can convert a cornea which is something like this to something as good as this. In the other eye as well, he had a good centration of the cone, but maybe not as good as the other eye, but he did see an improvement in his uncorrected and the best corrected vision. So broadly, how I manage keratoconus is based on whether it's early or advanced, and it is a busy slide. So when you're looking at early, which is grade probably 1 to 3 keratoconus, and you got progressive, if you have progressive astigmatism, if it's regular, it would still be a good idea to either give him specialty contact lenses or give him a pair of glasses. If it's progressed in terms of irregular astigmatism, more than 0.5 to 0.75 a year, a collagen cross-linking followed by a toric ICL is what I recommend. You could also do an intracorneal ring, and if he has high significant myopic astigmatism, an ICL can be put. If you got irregular astigmatism, an intact followed by a collagen cross-linking is an ideal way to proceed. And if you got grade 4 advanced keratoconus, like this patient with a lot of scarring, with poor best corrective visual acuity, a deep anterior lamellar keratoplasty works quite well. If you got a fairly diffuse cone with no central scarring, there are multiple options. You can do a collagen cross-linking even if the Ks are less than 60, follow it up with an ICL or a scleral contact lens. And in the left eye, in the other way, you could also do intact SK to reduce the irregular astigmatism, also aim to reduce the myopia in that patient. We did find that a lot of these patients tend to come a lot younger, and now almost about 50 to 60% of the patients are less than about 16. This is one other patient with a marine engineer with keratoconus with a contact lens use history of almost 10 years with a decrease in vision in both the eyes. And if you look at his case, he had fairly advanced cones, almost a grade 3 to 4, with irregular astigmatism in both the eyes, his left eye being worse. For him, the options were actually quite limited because offering a keratoplasty in this kind of a patient is almost impossible because he would then lose his job. So we planned a combination treatment for this patient. In the right eye, we did a collagen cross-linking, a hypertonic riboflavin-assisted collagen cross-linking, follow it up with a toric ICL. And in the left eye, we did an Intax combined with collagen cross-linking and followed up with a toric ICL almost about a year later. He now has about 612, 6/9 vision, is able to function well without glasses, and if he wants clarity, he does basically put his glasses on. Just a note about managing these patients. Sometimes if you got a residual high astigmatism with myopia, some of these patients do require a bit of planning because the surgery needs to be a lot more planned because the astigmatism sometimes will vary across the topography. The surgery itself is fairly straightforward in terms of putting the ICL, but remember sometimes if you go to the periphery, if there are rings, you would get a bit of distortion, so you need to be careful. This was done with the earlier method of ICL, so we did do a PI at that time. In terms of predictability of a toric ICL in keratoconus, in a 1 year follow-up in about 11 eyes, we do show that fairly good predictability. You're not aiming to actually get them a perfect 0, but in about a diopter and a half, the predictability is quite good. This is one other patient, a CXL done at an institute, software engineer, still having glare and halos, and not comfortable with either a glass or a rose-K contact lens. We did take him up for a laser-guided procedure, which was topography-based, and over a period of time, in about 6 months, he had fairly normal-looking cornea. So you do not get those results immediately. You would probably need to wait because there is a factor of epithelial healing, and most of them actually do quite well. Of course, DALC for keratoconus, a fairly established way of doing, but if there is scarring, I would definitely recommend doing a keratoplasty with the big bubble technique. The results in most of these patients is actually quite good. Some of them see 612, 6/9 unaided if the suturing is actually quite good. Of course, it does require a bit of care because you're dealing with the last 20 microns of the cornea. I do prefer a continuous suture in most of these patients, and most of them actually do quite well. In conclusion, specialty contact lenses, intracorneal rings, toric ICLs, and topo-guided PRK are successful surgical alternatives in patients with ectasia, which gives good improvement in uncorrected and best-corrected vision. Surgical options for irregular corneas using the Nomogram do give good visual outcomes, and a long-term follow-up indicates a continuity of the effect. Thank you so much.